Well, thank you, Kojo. My name's Adam Kanter. I'm also from UVA, like David. Now, I unfortunately didn't get the pleasure of actually really spending much time or getting to know Dr. Jannetta. Met him on a very few handful of occasions. However, I did go to UVA, as noted, and I worked a lot with Dr. Jane, and he was the father figure that I had who appears to have who appears to have had the same footprint in Virginia as Dr. Jannetta did here. So the bottom line is I get it. I get what he's done here, and I'm very honored and privileged to be able to speak here at a symposium under his name. So there appear to be a lot of themes that were set by Dr. Jannetta, and one here, if you look him up, never cut what you can't see. And that's actually a theme that is going to be apparent throughout what it is that I do, actually, minimally invasive surgery, performing from the side, and in doing so, it enables direct visualization, which was a lot of posterior procedures you don't actually get. So I'm going to carry that theme through my discussion here, but I'm going to be talking about lateral. So lateral access surgery, a lot of people know it as the X-lift or the L-lift or some form of IF, right, for coming laterally. And the primary goals are align, decompress, arthrodesis, and make maximum use of the anterior column, anterior support structures, right, which is convenient because it actually spells out my name. So I think it was actually meant for me. But clinical indications, right, this degenerative disc disease with instability, recurrent herniation, lateral disc stenosis, claudication, pseudoarthrosis. That's really what it's been known for the past decade or so, but we really come to push the envelope here, and I owe a lot of that actually to David Okonkwo, who spoke before me, so it's the perfect parlay into my talk. The fact is that a lot of the things that we're doing here, that I'm doing, is because David Okonkwo said, okay, are you ready for the next step? And I'll kind of show you as we move along, but I'm going to talk about some of the more advanced indications of lateral access surgery: scoliosis and deformity, some spondylolisthesis, trauma, and some thoracic pathology. And I'll try to move very, very quickly. So I'm not going to talk about the tiny incisions that we make, or the fact that monitoring is utilized, high-tech monitoring and nerve localization to create safe surgical corridors. But I'm going to talk about a very powerful procedure and something that can help dramatically align the spine, which is why initially it became so exceedingly useful in deformity surgery, and why, in fact, my very first patient that I ever performed this surgery on, we did 4 levels. We did a 4-level lateral interbody fusion on a patient that wasn't going to get surgery from anyone else. She had a terrible problem, and we didn't really have a solution. And we thought, well, we've got this new thing here, maybe we can give it a try. I know that sounds a little bit cavalier and kind of, we can do a 4-level lateral interbody fusion, having never done it before, but yeah, the answer is we did. And you can see, this isn't this patient, of course, but this is a dramatic, or a powerful procedure where you can get significant correction. You can see from pre-op to post-op, the amount that you can open up the central and the foraminal canal is significant, and again, all through small incisions. So advanced indications, let's talk about deformity and the anterior column reconstruction, or anterior column release. We were one of the first folks to do it. Yuan Uribe has been popularizing it and writing on it as well, and we're a part of that same group. But Dr. Okonkwo just explained the significance and the importance of sagittal balance, right? And it is the #1 predictor of improvement in a patient's symptomatology after deformity correction. Why do we need these? Why do we need these newer techniques? Well, if you look at a systematic review, it shows about 40% of patients undergoing deformity surgery end up with a complication. The ISSG, which is a group that Dr. Hamilton and Dr. Okonkwo and myself are honored to be a part of, they looked at 950 consecutive patients, and what they found is when you look at the patients that had complications versus those that didn't have complications, is that the major complications appear to be more related to the procedural variables than the patient variables themselves. And one of those major complications is, of course, blood loss of greater than 4 liters occurring in large deformity patients. And this led to our paper that we wrote back in 2010, where we talked about radiographic and clinical improvements as well as complications in this patient population. We found that we were doing pretty good. We were straightening people out. We were cutting their apical vertical translation in half. We were improving their VAS significantly. We weren't doing a great deal of improvement for their lumbar lordosis, because this is really a distractive procedure. So that was what was going on at the time, and here's a typical example. And what we started doing is actually working from the back, coming from the back, trying to create a loose, flexible spine in these patients. Dr. Okonkwo would place these pedicle screws and perform osteotomies, and then I'd get to come on in and perform this nice, powerful procedure now that we have a very flexible spine. And you can see pretty dramatic improvements, and there's the screws are now lining up, and this is the end result. And this is the end result at 12 months, showing that's something that holds true. And this is in 2014. We're doing a whole lot of writing now. We're involved with the ISSG. We're talking about radiographic and clinical outcomes following combined, and this is what was just initially presented as combined procedures. We're performing these lateral access interventions and combining them with open procedures from the back, and we had excellent results. But what's really impressive, if you look at the top there, that shows the pre-op lumbar lordosis versus the pelvic incidence, and you can see there's a significant difference. And what we found is that if you can get those two to be within 10 degrees of each other, you're going to have a dramatic improvement in the patient's long-term outcome. And that's what the bottom graph shows, is PI to LL, showing that they're lining up rather nicely, certainly within 10 degrees. And we continue to write on the merits of this procedure that we're performing, showing that there's significant improvements when you perform this procedure minimally invasively, and what you can see here is the blood loss is pretty dramatic. When you perform hybrid procedures, so the minimally invasive portion, but you open up the back, you're getting still 2 to 3 liters of blood loss. When you do it open completely, it's 2 to 4 liters almost of blood loss. But when you're doing it circumferentially in a minimally invasive fashion, it's under a liter, under half a liter, and that half a liter is not occurring during the lateral portions of the procedure. Again, comparing these hybrid approaches to CMIS, we found complication rates were higher with the hybrid approach than with the circumferential minimally invasive procedures. And we continue to look at these complications. You can see intraoperatively the percent of complications occurring when you perform the procedure open is significantly higher than when you perform them in a minimally invasive fashion. What we did find, though, is that there's a ceiling. You can only do so much through these small portals. And we found that if you had a severe scoliotic deformity, you need to do something that's a bit more extensive than what we're capable of doing from the back. And this enabled us to then work again with the ISSG and create an algorithm. But you can see if a patient had a PIL mismatch of greater than 30 degrees, significant kyphosis, or they had an inflexible curve, you're moving over towards class 3. You end up doing an open procedure. This is what we see here. This is what was presented with performing pedicle subtraction osteotomies, which, as noted, you can lose 1 to 2 liters of blood just during that portion of the procedure. So you're essentially watching your blood walk right out of the hospital. So welcome to ACR, anterior column reconstruction. This is a patient that had a severe sagittal imbalance. You can see 165 millimeters of positive sagittal balance. And here's the procedure being performed. Above and below, we performed straight laterals, and then here's the graft going in, the hyperlordotic graft, anterior release of the anterior longitudinal ligament, significant correction, significant lordosis correction. You can see the patient then had the mini-open ALL release and placement of an ALIF, and this is the patient after having only had this portion of the procedure, this stage, and to try and put it in pre and post, pre-post coronal, pre-post lateral, you can see dramatic improvement. The patient is now far more erect and upright, and the patient's head is now on top of their pelvis. This is before we came from the back at all. Remember, this is just from the front through these 1-inch incisions. So that's pretty dramatic, at which point it's then a lot easier to come from the back, and these are the percutaneous screws that David places, and pretty significant correction from pre to post-op. This is a patient that we did just this past week. Similarly, this patient had previous surgery, and this is great. This is a great operation for patients that have had previous surgery. Coming in, performing, you can see the significant distraction, the hyperlordotic graft placed, secured, significant improvement, and we also did the level within the previous construct because of a pseudoarthrosis there. Did a single level ALIF graft, and you can see from pre-op 24 centimeters of sagittal imbalance with a PIL mismatch of 48 degrees. After only the lateral or the anterior intervention, you can see only 9 centimeters of sagittal imbalance, and the PIL is now within 16 degrees once the screws were placed we're within our numbers that we want to see. So dramatic improvement in these patients. So the ACR, anterior column ligament sectioning, hyperlordotic graft placements, expanding the anterior column as opposed to compressing it from the back or contracting it, restoring lordosis and realigning the spine with an average blood loss of about 10 cc's. Pretty dramatic. This is the modern day PSO. So let's move on to talk a little bit more about other advanced indications of lateral surgery, spondies. And I'm not talking about the simple bread and butter stuff where we all see these immobile spondies, grade 1s. These are very easy. These are no-brainers, right? But I'm talking about more significant spondylolistheses. So patients that have high grade 2s, right? And you got to be careful because you have to be able to find that midline, that center. But significant disease, however, we can get excellent restoration by placing an inner body graft in that space and then going ahead and supplementing with fixation from the back. And how does this do in the literature? Well, pretty darn good. We can see we can get dramatic improvements in patient outcomes, decrease in ODIs. You can see that even in the worst case scenarios, performing this procedure at L4-5 with grade 2s, significant improvements in these patients. Substantial clinical benefits. Again, you can see all the clinical measures that we record improving. Also in standalones, when you select the right patients, you can also get excellent clinical results, and this is from Dr. Pimenta's group. Massive, significant improvements in all clinical outcomes measures. What about if you compare to PLIF or TLIF? Again, very similar improvements. LIF is providing a less invasive mechanism via indirect decompression to achieve a similar clinical result. If you compare it to MIS TLIF, similarly, no significant difference in outcomes. So I'm not saying that this is the way everybody needs to treat their spondylolisthesis. What I'm saying is that it's great to have this tool in your belt so you can do it in a less invasive fashion, a lot less blood loss. Here's the comparison to ALIF, showing no difference in clinical outcomes, no difference in complications, and no difference in fusion rates. So we've got another tool in your tool belt to perform via indirect decompression, taking care of these patients. And you can see pretty dramatic improvements in realignment and decompression. What about trauma? I remember the day I came to the office and we were performing these lateral procedures for a lot of for the deformity, and David said to me, he goes, "Okay, you ready to take it to the next level?" I said, "I'm not sure what you're asking for here." He goes, "I need you to take me to T12 from the lateral access portal," and this is how we've been helping take care of a lot of thoracolumbar burst fractures. So we extrapolated what we do laterally, and we decided to do the same to treat burst fractures. So using our dilators, inserting them between the ribs, you can see dropping the main dilator down, again, hopefully not on top of the segmental artery, but close by. Using monitoring techniques, using the same techniques that we use to perform lateral access inner body procedures, except now we're taking out the entire vertebrae, performing total discectomies. And here's a couple cases. This is a patient that had a significant burst fracture. You can see coring out the disc space above and below, and then removing all the intervening bone, placing the cage, expanding the cage, placing a lateral plate, fixating the plate, and you can see pretty significant procedure for a relative minimalist approach, and the cosmesis is quite nice. And this allowed Dr. Ganthoek, one of our fellows at the time and residents, to then write up the technical nuances of performing this procedure, which was published shortly thereafter. So here's, again, a few more quick examples, but pretty significant severe pathology, right? In the old days, when I say old days, not that long ago, this patient gets a shark bite incision. This patient gets a big operation from the side, and then significant number of multi-level fixations, segmental fusion from the back. And in this situation, we come in from the side. There's the cage going in. You can see expansion of the cage, realignment of the spine, placement of the lateral graft, or I'm sorry, lateral plate, and significant decompression. And you can see the cosmesis once again, quite minimal. Now, this isn't something you want to do at 2 a.m., right? So I'm not suggesting every burst fracture gets treated in this manner. However, when this patient comes in with significant canal compromise in the middle of the night, you know that you can do a decompression, you can do a short construct, knowing that you can come back in the following morning and you can go ahead and perform the vertebrectomy and get the cage in there. So it allows us to change what we do. Speaking of thoracic, this is a case actually this is something that we've been doing a lot of now for thoracic pathology. that the benefits are minimally disruptive, small incisions. Here we don't need to resect the rib. We work between them. You don't need to deflate the lung and the potential complications that come of that. Again, very minimal blood loss and direct visualization. This enables direct lateral visualization for taking care of significant pathology. Of course, the potential complications of thoracic surgery still exist. However, the majority of these luckily occur below our caudal to T8. And there's other considerations, of course, where the diaphragm attaches and knowing how to release that, knowing where the neurovascular bundle is and making sure that we work above the ribs. Counting, right? No matter what we do in the thoracic spine, it's most important that we find the right level. But again, working through the incision, starting posteriorly, creating a dorsal trajectory and working our way anterior to land laterally atop the spine, returning the retractors around using spatulas now. We have all kinds of nice instruments that enable us to get down there and basically get down. Now you got to remember though, when we get down there, we still have to perform the same procedure, right? You still have to perform wedge osteotomies and perform the discectomy just as you would if you were going to perform the procedure through the shark bite incision, except now we can do through these minimally invasive portals, and cages can also be placed through the same portal in the same manner. So this is a procedure, this is one of the cases, coring out of the disc space. And again, important to remember, you got to remove the rib head. You have to identify the pathology, core out the disc itself, perform your wedge osteotomies, and then remove the material, the offending agent, into the void that was created, followed by placement of the cage. And here's a couple quick cases showing what we've been capable of doing. Pretty significant. This is soft disc pathology at T910 in a relatively young woman with signs of myelopathy. This in the past has required big incisions, big operations, significant recovery, and tremendous complications. And this was not a calcified lesion. However, we were able to come in, perform the procedure through the minimally invasive portal. You can see the same procedure is performed, except it's done through a 1-inch incision. You can note the anterior CSF in the signal. And this is one that we just did very recently on a scrub tech. She was having significant symptoms of myelopathy, but her problem, as you saw earlier, is this is fully calcified, causing significant enveloping of or impingement within the cord itself, which was enveloped around the lesion. And similarly, we came in from the side through a very small portal, and this lady went home the next day. So pretty significant improvement in a patient. This is her post-op imaging. So key points when surgery is indicated in thoracic pathology, and again, we got to be aware 20% of the population, right, has asymptomatic thoracic pathology. But when it is indicated, anterior approaches are favored for centrally located as well as calcified herniations. An MIS option can be safe and equally effective as the open options, as long as you carefully evaluate and know your limitations. Key surgical steps must still be performed, right? Minimally invasive cannot mean minimally effective. And you want to minimize the spinal cord manipulation, and this is what enables you to do so without having to work around the cord itself. So in conclusion, minimally invasive lateral techniques can enable safe, effective treatment options for a variety of spinal pathologies. Every patient must be individualized and carefully evaluated. And these procedures that we perform must be scrutinized, right? And quality assurance measures performed to make sure that utilizing standardized outcomes measures to make sure we're doing the right thing here. And the hospital administrations must invest in these outcome systems and personnel in order to help us validate and perform cost-value analyses. So one thing I would say to our group of residents back there is that, again, having not known him, but never cut what you can't see, my suggestion is continue to evolve, continue to push the limits until you can see it. Thank you.